Good morning, everyone. I think we'll start the session. Sorry for starting a little bit late. We had a couple of technical difficulties with PowerPoint this morning, but it seems to be resolved, so hopefully it all runs smoothly. Today we have some great talks. The first one is from our PhD fellow here at NCAS, Courtney Ierano, who will be discussing antimicrobial stewardship for surgical antimicrobial prophylaxis. Thanks, Courtney.
Good morning, everyone. Thanks to everyone listening in online as well. I think we've got 18 people listening online at the moment. So to get the ball started, so we know surgical antibiotic prophylaxis is a common infection prevention measure for surgical site infections. We want to prevent surgical site infections because they occur in approximately 2 to 13% of procedures in Australia, and almost half of them are considered preventable. And when we talk about preventing them, it's through the use of antibiotics, along many other measures. When infections do occur, there's significant cost to the patient and the healthcare system, and that doesn't also factor in attributable costs such as the things like length of stay and personal injury and things like that. When we talk about surgical antibiotic prophylaxis prescribing, there's many elements or components of prescribing that we need to factor in when we talk about what's appropriate or not. So we look at the indication, the antimicrobial of choice, the route of administration, timing, dose, intraoperative redosing, and duration. When we refer to these principles, we look at evidence-based guidelines. So in Australia, it's the antibiotic therapeutic guidelines, antibiotics. In terms of improving antibiotics for surgery, one key component is antimicrobial stewardship. There's many benefits of antimicrobial stewardship, and that includes improving appropriateness of prescribing. By reducing use, we're then reducing the risk of resistance, morbidity, and mortality, reducing costs to both pharmacy, patient, and healthcare system, and as well reducing consequences of antibiotic use, such as side effects and toxicity. When we look at reducing the risk of antimicrobial resistance, it's been acknowledged that this problem is both biological and social. So when we try and develop stewardship interventions, we don't need to just focus on just the clinical component, but also the social issues underlying these problems like cultural, political, environmental, and economic. In terms of the Australian response to AMR and stewardship, there's a lot going on. So there's a range of government, non-government bodies, guideline resources all throughout Australia. And as you can see, there's a little bit of focus in Victoria as that's where they're based. So one of those is through the National Centre of Antimicrobial Stewardship. They have developed the hospital NAPS, the National Antibiotic Prescribing Survey. And this has been implemented across Australia, and for the last 4 or 5 years, it's identified that surgical prophylaxis was the most common indication for antibiotic use in Australian hospitals, therefore represents a key target area of improving antibiotic use. When we look at the appropriateness of antibiotics for an indication, down the bottom there, we can see that surgical prophylaxis had the highest rate of inappropriateness. So in summary, antibiotics are prescribed commonly for surgery, but also at high rates of inappropriateness. Following on from this, the surgical NAPS was then developed. It took a different methodological approach, allowing the antibiotics to be captured across the patient's journey as an inpatient, looking at antibiotics prescribed before surgery as existing therapy, procedural doses, and post-procedural doses. And you can see that from the pilot data here, that antibiotics were prescribed still at higher rates of inappropriateness, but more so in the post-procedural setting. And this was more noted when we looked at specifically at guideline compliance. And one of the big indicators was when antibiotics prescribed but not indicated at all. And this bigger difference was seen in the bottom table, bottom row there, where 10% of antibiotics were prescribed procedurally that weren't indicated at all, compared to 40% post-procedurally. So as part of my PhD, one of the first things I did was look at the evidence for surgical prophylaxis. And basically, it was one, just to get my head around the topic. We can see that antibiotics are prescribed poorly, but I mean, like, why aren't we following evidence-based guidelines? So the first source was, well, let's look at the evidence. You could see this paper, we looked at level 1 levels of evidence because that was considered the gold standard, so systematic reviews, meta-analysis. And basically the summary was, from that information, a lot of the literature was published 20, 30 years ago. So it's perceived that it might not be as relevant to the current Australian prescribing landscape. And that's why, in summary, the most important thing is that we need to acknowledge this evidence, but then use expert consensus to blend new evidence that's not of greater or higher levels with the existing evidence and factoring that in with the Australian prescribing landscape. Also to this, well, we're like, well, the evidence isn't awful, so maybe there's some other reasons why we're not prescribing antibiotics appropriately in surgery. So that then led to issues regarding guideline implementability and their uptake. And are we providing our hospitals with enough resources to implement these guidelines and improve antibiotic use? For Antibiotic Awareness Week 2 years ago, we also wrote a commentary piece targeting those principles of surgical prophylaxis in the general practice setting. So we noticed that there's a gap. We don't capture any details of when antibiotics are prescribed in an outpatient or in general practice settings. And so we wanted to engage with our GPs as well to let them know that they can actively be involved in this topic of research too. And I put down the bottom there that maybe the new development of the general practice NAPs might be able to capture this data. So following on from this, I conducted my first project in my PhD, and that was evaluating the implementability of the therapeutic guidelines. We adopted a purposive sampling using the guideline implementability appraisal instrument, and that essentially consists of 9 dimensions that looks at how implementable a guideline is, factoring in global considerations of the guideline itself, its executability, decidability, validity, flexibility of the recommendations, measurability, and computability because it's an electronic guideline as well. So we recruited ID physicians, anaesthetists, surgeon, infection control consultants, and AMS pharmacists. What was novel about this work is that the Australian Surgical Prophylaxis guidelines hadn't had an implementability review before, and overall it was generally implementable, but borderline facilitators and barriers do exist. So to support the facilitators that we identified is to continue auditing antibiotic use through the surgical NAPs to measure adherence and uptake, and advice to guideline developers that they consider patient and practice characteristics to support the flexibility of these recommendations. So what do they do in obesity or if the patient's already on antimicrobial therapy? In terms of barriers, we recommended increasing engagement with surgical craft groups in the actual guideline development, provide greater resources on transparency of the evidence behind these recommendations, conduct ongoing appraisals of guideline implementability, as this was conducted on the previous version of therapeutic guidelines. The new version came out in May this year. Developing ongoing implementation resources and tools to support the recent update as well. My second project, we continue to use the surgical NAPs data to identify areas of pretty much get a greater understanding of the current prescribing of surgical prophylaxis in Australia with a much larger data set, as surgical NAPs has continued to roll on and collect more and more data over the last couple of years. This was recently published in Journal Open, and the key points from that are on the next slide, but we adopted some statistical methods that enabled us to calculate an adjusted appropriateness. So you have your raw appropriateness of prescriptions, but then after factoring in a range of variables like age, gender, surgical procedure, we then get this measure of adjusted appropriateness. And then from that, you could see that the overall rate of prophylaxis is still low at 49% appropriate. And then when we looked at adjusted appropriateness across the surgical craft groups, this was still low, but it obviously varied across the specialties. So procedural doses, it was 34% for dentoalveolar surgery compared to 69% for neurosurgery. Similarly, when we looked at post-procedural, that rate was even lower, 22% for breast surgery and 59% for ophthalmological procedures. In terms of reasons for inappropriateness, timing continued to be the most common reason for inappropriate procedural prescriptions, and duration greater than 24 hours for post-procedural at 54%. So in conclusion from this project, we've identified that there's high rates of inappropriateness across all surgical craft groups. The reasons for inappropriateness could vary according to the type of surgical prophylaxis, so procedural, post-procedural, and across surgical craft groups. And this big body of work has then highlighted that, yes, we still need to continue improving surgical prophylaxis prescribing, but we've also highlighted some potential targeted areas of action for stewardship. This third project is underway at the moment. So we've got a lot of data in the surgical naps, and orthopedics is one of the most commonly audited procedures. So we've done a subset of just looking at the orthopedic procedures. What is good about the surgical naps is in the previous paper, we just broke it down: cardiac, ortho, abdominal. But surgical naps has so much more data, we can break that down. So the orthopedic, I've got a snapshot of the sub-analysis from this body of work, but we can get data that's more meaningful for surgeons. So an orthopedic surgeon is going to look at the previous rate and be like, I don't know where I fit into that. But if they're predominantly conducting arthroplasties or hand procedures, we can give them a similar adjusted rate of appropriateness, and that can be more meaningful. This paper at the moment can just identify, again, that we're performing poorly, but then more specifically which procedures probably need a little bit more support and guidance. Or in some cases like arthroscopy diagnostic, antibiotics aren't indicated at all. So it's interesting that they still had an appropriateness of 36%. So again, using the data to identify targets for stewardship. The next project I'm also working on at the moment is using that data to look at procedural antibiotic choice. So similar methods that we've done before, but it's more focusing on broad spectrum antibiotic use and why we're using broad spectrum antibiotics for surgical prophylaxis. Could it be allergies? Could it be the complications associated with the procedure? Evidence doesn't really recommend them. So we wanted to see what information have we got in the surgical naps that could identify any variables or factors that are influencing this broad spectrum use. So in this example here, from that data set, so inappropriate surgical prophylaxis, there were 687 prescriptions that were identified as the spectrum being too broad. That was only 14% of all procedural doses. So there was plenty of other reasons for inappropriateness, but specifically focusing on broad spectrum, you can see in the top corner there, looking at antibiotics across the surgical procedure group, you can see that highly condensed in that top left corner, broad spectrum cephalosporins, aminoglycosides, and glycopeptides contribute to this component, and more often in urological, orthopedic, abdominal procedures. So again, highlighting potential targets. Of interest, you can see cefazolin, which is a recommended antibiotic, is there, but a lot of that is with dentoalveolar procedures. So was it that cefazolin was too broad, or because it just wasn't indicated at all? So the surgical naps has many applications, and it's great to see that we can use this data to identify and pinpoint different areas to improve antibiotic use. The last project is a big qualitative project that recently just got published. It's titled Influences on Surgical Prophylaxis Decision-Making by Surgical Craft Groups, anaesthetists, pharmacists, and nurses in public and private hospitals. We conducted a qualitative project with focus groups and semi-structured interviews to try and identify what barriers and enablers were of appropriate prescribing. So wanting to understand what sort of influences were leading to antibiotic prescribing decisions. We conducted a thematic analysis, and we adopted a theoretical framework, the TDF and the COM-B, to develop and categorize these themes. There's many benefits of adopting theoretical frameworks. They help increase our understanding of behaviour and behaviour change, which of course, antibiotic prescribing is a behaviour that we then want to change. So we need to know more about it before we go and develop any stewardship interventions. And by doing this, it then increases the appropriateness of that intervention if it's been theoretically informed. So the framework that I've used is the behaviour, the TDF, which is the yellow, and that is mapped to the COM-B in the green. And then what we identify from that is then mapped into this greater process called the behaviour change wheel. So by identifying a skill as a barrier, that gets mapped to the physical component of the COM-B, and that then informs interventions in the red. So obviously more training to improve this skill would be an appropriate intervention. And then when you look at policies in the outer ring, that then maps to guidelines. So it then provides like a structured approach to what interventions would be appropriate to the barrier that you've identified. So the overall results from my qualitative work is that we identified 6 key themes. And then from that, a whole range of sub-themes. So going through them, the first theme was that antibiotic prophylaxis was considered a low priority skill for surgeons. And then from that, we've got 2 sub-themes that were both identified as barriers. So because it wasn't a priority of a skill, then other people tend to do it, such as anaesthetists administering and prescribing surgical prophylaxis. But then a quote from an anaesthetist here is, you know, we're now being discouraged from doing that because we're de-skilling the surgical residents. They're not learning how to do this because we're doing it. So it's considered a low priority for them, but then they don't want to not do it at all because then they don't have the knowledge and the ability. So there's got to be a bit of a balance with the roles for surgical prophylaxis. Another being that the acknowledgement that surgical technique was more important than giving antibiotics. And we've got that here when a colorectal surgeon said that, I don't think I can overcome my failings with antibiotics. Surgical technique has much more importance to the procedure. So in terms of making recommendations for change in relation to this theme, providing targeted education and training on surgical prophylaxis to meds as part of their surgical orientation, but also increasing surgeon engagement in the workflow for surgical prophylaxis decision making. Another theme, prescriber autonomy overrules guideline compliance. So the 2 sub-themes from that was that guideline knowledge and awareness of limitations. So a colorectal surgeon here identified that the guidelines are there, but they're not the rules, so they're not going to make me stop worrying. If I'm concerned, I'm not just going to follow the guidelines because they're the guidelines. So there was a greater reliance on using their clinical knowledge, and that they felt that trumped any form of guideline. And then whereas, in a more positive note, the sub-theme, competition as a means to regulate behaviour, we identified that surgeons are pretty competitive. If you can identify and give them their audit data and show that they're at the bottom of the pack, they're more likely going to want to improve. So knowing about their behaviour, we can then provide targeted things like giving them regular feedback to help improve their practice. So in terms of those recommendations for change, we want to increase accessibility of guidelines, again, increasing engagement with surgeons and anaesthetists in guideline development, and possibly look at mandating the documentation of why they're not prescribing according to the guidelines. In terms of the competition, we want to continue providing feedback to our departmental heads to facilitate benchmarking at multiple levels, so from consultant to the unit to hospital to state and then nationwide. Social codes of prescribing reinforced established practices was another theme, and these 2 were identified more commonly as barriers. So down the bottom there, intraspecialty hierarchy rules. So a surgical resident highlighted that at the end of the day, if we wanted to generate change, it had to be put back on the consultants. More often than not, they're just going to go on board with whatever their bosses tell them. They're not going to change it because that's the status quo. That's what they do. In terms of cross-specialty prescriber etiquette, a good quote from one of the private pharmacists noticed that even though the surgeons might get infectious diseases to come do a consult, it's still all rather polite. Even though the ID guys know that the antibiotics could just be ceased, they're not going to go and cease it out of courtesy to the surgeon. But in the private setting, by the time the surgeon goes around and reviews that, could be a whole nother day's worth of antibiotics. So it's all very polite, and everyone's being mindful of everyone in that space, which I mean is obviously important too, but at what cost does that come to antibiotic use? So in terms of recommendations for change, we again need to target any stewardship interventions in surgical space at the consultant level. We need to engage with them, not only just with rollout, but developing, implementing these projects as well. Another theme, the need for improved communication, documentation, and data for action. And on a positive note, the timeout supported preoperative communication. As you can see in the nurse there saying everyone uses the timeout, not so much sure about guidelines. So we want to then capitalise on using a successful component of stewardship and safety checks in the surgical setting. However, when it came to post-operative management, the documentation was considered pretty poor. And even the anaesthetic record was more of a record rather than a prescription. So it's sometimes done in retrospect. It might not be documented properly at all. So there's definitely, for us to audit antibiotic use, these measures need to be in place to ensure that it's meaningful and accurate. And down the bottom left, a theme of data for action, which was considered an enabler. An orthopedic surgeon said that to generate change, if you really want to convince surgeons to change their practice, we need to audit it, compare it to previous use when antibiotics had been prescribed, and compare it and show that there hadn't been a change. So essentially highlighting that there's a need to present data on surgical outcomes and showing them that there is no benefit from using antibiotics post-operatively, but also potentially harm as well. That's what they said was required for change. So in terms of recommendations, again, we want to promote the standardization of surgical prophylaxis workflow and documentation, looking at indications, duration, and also detailed antibiotic management plans, such as the hospital discharge summary that then goes to the GP, and also plans for re-referral when an actual infection has occurred. We can do this by also capitalising on existing recommendations or workflow processes, such as the timeout, and modifying that to include a discussion about post-operative antibiotics. And there's also potential for the use of clinical decision support systems and electronic funds for surgical prophylaxis. In terms of the data, we want to again engage with surgeons to identify what's relevant quality indicators, what's meaningful for them. Like, we can collect all the data in the world that we want, but if it's not going to be relevant and encourage surgeons to change the practice, then what's the point? Another big theme is fear and risk of perceptions, and that was identified as being a barrier to appropriate surgical prophylaxis prescribing. There's issues of fear-led litigation, in which a colorectal surgeon highlighted that the behaviour of private insurers and how that puts pressure on surgeons to mitigate against the risk of infection, and they're more likely to give antibiotics. Also, just the fear of infection in general, it was considered a nightmare. Like, no surgeon wants to cause their patient harm, and if there's a perception that giving antibiotics is going to stop that, then sure. Another is that this risk varied across the different specialties. So we need to tailor the interventions to the specialties and their potential concerns. So our colorectal surgeon here said, you know, we deal with poo all the time, but if you put poo on a plastics wound, the plastic surgeons would flip out and not cope with that at all. But they're not concerned with things like that because they're exposed to a dirty field already. And then another sub-theme, how questioning consultants, the junior surgeons felt that they're going to be perceived as annoying or stupid and not be respected and considered a hassle, and that would then affect their employment opportunities further down the track. Questioning surgical prophylaxis didn't seem to be worth the risk. So things to do about that, again, collecting local data to support that prolonging durations of antibiotics don't necessarily improve outcomes, and again, might cause harm. In terms of litigation, getting support from for stewardship for surgical prophylaxis at an executive level. And again, there's a whole nother research project that could be looking into the impact and influence of private health insurers and surgical prophylaxis prescribing. In terms of career progression, we want to increase the awareness of current fears and issues facing junior surgeons, and collaborate with the College of Surgeons to help contribute to their plan to build a culture of respect and supporting decision-making and questioning of decisions for prophylaxis. And then again, with the varied risk, as I mentioned, we need to tailor stewardship interventions to address the specialties concerns. Finally, lack of clarity regarding roles and accountability. The three key sub-themes here was that surgical prophylaxis was normally passively prescribed. So it was just continued post-operatively, continuing the status quo until someone finally got the nerve to ask the boss, can we stop this? And again, access to those senior decision makers seemed to be a gap in care. Of course, the primary responsibility is still faced with the surgeon, so the buck stops with the surgeon was a common quote throughout our focus groups. So, but interestingly enough, one pharmacist noticed that in their hospital, the anaesthetists are owning it intraoperatively, and that's where they say the prescribing is done quite well. But once you go into the post-operative setting, there's no real ownership of surgical prophylaxis. Who should be stopping it? Who should be reviewing it? And that's where you see a large variance in practice. And then finally, the role of pharmacists and nurses in the surgical space is not as critical to surgical prophylaxis as it is for anaesthetists and surgeons, but there are still potential for them to be more engaged in this space. And anaesthetists notice that nurses are much better at following guidelines, and same as ward pharmacists. If there's a standard protocol in place, they're going to be at the forefront of implementing it and making sure it works, which is a good thing to factor when you want to design a stewardship intervention. So again, summarising recommendations for change is that there needs to be greater collaboration between surgeons, anaesthetists, and all health professionals in the setting to develop a standardised pathway or workflow that defines the roles of these professionals in this space for surgical prophylaxis prescribing. With the adoption of e-health and electronic prescribing, that may support this as their names are electronically time-stamped to when they decide to start and stop medications. So that might give them more accountability in their decisions as well. And then for the role and expansion of pharmacists and nurses, looking at partner and collaborative surgical prophylaxis prescribing models. And again, modifying enhanced recovery after surgery pathways. By doing that, it can then have some defined roles and expectations of antibiotic prescribing in that space. So that was a lot of information. So in summary, there's multiple factors that influence the state of prescribing of surgical prophylaxis. Education is not a solely effective approach. We need to, because surgeons, they were aware of the evidence and guidelines, they still just chose to do what they wanted to do. So we need to address a range of other issues, looking at hierarchy, those roles and responsibilities. We need to develop resources to support documentation, that data for action, but also factoring in the surgeons and their specialty-specific concerns. And adopting a theoretical framework to do this allowed me to do it in a meaningful way, develop targeted interventions, and we can further apply the outer rings of the behaviour change wheel to, again, tighten this down into some defined theory-informed interventions. So in summary of stewardship for surgical prophylaxis that currently exists in this space, so the Cochrane review looked at antibiotic prescribing in hospitals, or stewardship for antibiotic prescribing in hospitals. Only 11 studies though looked at surgical prophylaxis. So, and the methods for these interventions were audit and feedback, and then I've highlighted that surgical naps is the perfect example of that in Australia. Restriction, physical reminders such as electronic prompts, educational outreach, academic detailing, and educational meetings through the use of guideline dissemination, antibiotic policies, and so forth. So there's a range of interventions that already exist in this space, but it's more how can we fine tune those now that we know the underlying behavioural issues to then identify potential more appropriate interventions. And that's essentially what I've done. So after all the work that I've done, factoring in all this information, I've proposed a framework for stewardship for surgical prophylaxis. It involves collaboration and engagement with colleges, the commission, therapeutic guidelines, and then focusing on data, getting meaningful data that we can generate actions and stewardship interventions for. So the surgical naps is currently being redesigned, and then a whole new process of implementing and education around that is a whole nother opportunity there, and using the data that we've got for identified targets. So procedural timing, post-procedural duration, topical use, high volume surgeries such as orthopedics, broad spectrum use. And then interventions based on that information from the qualitative work. So education, electronic prompts, modifying existing pathways, and standardizing post-operative documentation. So looking to the future, ongoing work is still with the surgical naps. We could conduct an updated GLIA appraisal with the new therapeutic guidelines. There's a lot of work that can be done to link surgical site outcomes with our surgical naps data. And then with that framework, obviously, I'd like to refine that, implement that, and then evaluate it. Here are my references. Thank you, everyone. I'd like to thank my supervisors and NCAS, and obviously the co-authors on all of my work. And at NCAS, yeah, there's a lot of people involved and helping me with the work that we've been doing. So thank you. Sorry about that.
All right, thanks, Scott. And before Rod introduces Lolita, are you happy to share? Okay.
Yes, can you see my screen?
Yep.
Not yet. Just one moment. Can you see it now?
Not your PowerPoint, no, but we can see that you're sharing. Blank at the moment.
Can you see it now?
No, we still have a blank screen.
Okay, one moment. Let me try again.
It did come up briefly just then.
It did? Okay.
Yeah, so maybe it's...
Let me swap.
Perfect, thank you.
Thanks, Courtney, for a great talk, and you've done a lot of work in a few years, which has been amazing. Moving along, we will now transfer to Lolita, who's joining us from the CEC in New South Wales, so hopefully the technology works very smoothly. And I'll move straight across to Lolita to talk about improvement science for surgical antibiotic prophylaxis. Thanks, Lolita.
Thanks, Rod. And thank you, NCAS, for the opportunity to present, particularly through Antibiotic Awareness Week. So happy Antibiotic Awareness Week all. So first of all, I'd like to acknowledge the traditional owners of the land. I pay my respects to their elders past and present. So today I'll just be giving you a background to the problem that is surgical antibiotic prophylaxis, or SAP. Might go through this quite quickly, seeing as Courtney did a wonderful job about that. I'll talk about the interventions that have been described in literature to improve SAP, an introduction to improvement science, and explain the difference between improvement science versus implementation science, and how we at the CEC used improvement science to improve SAP. So, as Courtney said, surgical prophylaxis is the most common indication for antibiotics prescribed to inpatients in Australian hospitals, and results from that show that it has been so since 2013. There hasn't been much change in recent years, and so it's about 30% of inpatients SAP prescriptions exceeding 24 hours in duration, and that's quite similar to the performance in New South Wales and ACT in 2016 and 2017. In terms of procedural prophylaxis, results from SNAPs show us that 34% of prescriptions were deemed inappropriate, mostly due to timing, dosage, or the incorrect spectrum. And post-procedurally, prescriptions were deemed inappropriate due to duration, dosage or frequency, or the spectrum being too broad. So there were key drivers for change in I guess, shifting the focus on surgical antibiotic prophylaxis, and most significant would be the inclusion of SAP monitoring into the national standards. So in November 2017, the Australian Commission released an advisory which stated that health service organisations should ensure SAP is included and addressed as part of their AMS programs, that they should monitor according to the AMS clinical care standards, and that they need to have evidence of action in response to any issues that they've identified. So version 2 of the National Safety Quality Health Standards, the service standards were released or effective as of January this year, and stipulates that an AMS program has to incorporate core elements and recommendations from the AMS clinical care standard, of which Quality Statement 9 refers to surgical prophylaxis. So this caused a lot of concern in New South Wales, and so we thought, how could we help support sites with improving surgical prophylaxis? So first of all, I'd like to kind of paint the scene and describe the interventions used to improve surgical prophylaxis in the literature. So I looked at recent papers from 2018 to 2019 on interventions used to improve SAP in different settings around the world. So the first paper was published in March 2019, and it was looking at the impact of a pharmacist-led AMS interventions to improve SAP in obstetric and gynecological surgeries in 2 tertiary public teaching hospitals in northern Nigeria. Obviously, Nigeria is a developing nation. It's a poor resourced setting in comparison to Australia. So the method that they used was prospective pre and post intervention study in the 2 hospitals, and the period of each was for 3 months. So the interventions that they introduced was they developed a protocol, which was developed by a team comprising of about 4 to 5 consultant obstetricians and gynecologists and a clinical pharmacist. And the protocol was then presented to the department by the clinical pharmacist before adoption. They had an educational meeting, which was organised during the department's own clinical meeting, and focused on the principles of SAP for obstetric and gynecological surgeries. This again was presented by a clinical pharmacist. And the last intervention was audit and feedback. So they collected data during the pre-intervention phase, and they presented that to the clinicians and highlighted areas where their practice did not actually perform well or did not align with guidelines. So in terms of results, they were able to achieve an increase in compliance with antibiotic administration timing and duration, as well as reducing the prescription of third-generation cephalosporins, redundant antibiotics, so where they had more than one agent and there was an overlap in spectrum. Antibiotic utilization was decreased, as well as the cost of antibiotic prophylaxis. It was noted that there was no significant difference in the rate of surgical site infections between the 2 periods at that facility. The second paper was published in April of 2019 and looked at improving intraoperative redosing of SAP during paediatric surgery in an academic paediatric hospital in the US. So they wanted to increase compliance of antibiotic redoses at the appropriate time and ensuring appropriate weight-based doses to 70%. So the method was that they reviewed surgical cases between May 2014 and October 2017 that required antibiotic redosing. In May 2015, they introduced an institutional change where they changed the recommendation for cephazolin dosing from 20 to 30 milligram per kilo and recommended redosing every 3 hours. And so what they did was have phased interventions to improve compliance of antibiotic redoses. So in terms of the interventions they chose, so they have an anesthesia electronic medical record, and what they did with that is displayed previous and next dose timing and had an alert which popped up 5 minutes prior to the next dose or the redose, as well as a weight-based dose recommendation. So, I mean, looking at the gaps, this is something we don't currently have in New South Wales and probably a few sites across Australia. And so their anaesthesia records are in the EMR, and so this institution uses EPIC. So in addition to that electronic kind of countermeasures, they had physical countermeasures. So they distributed antibiotic redose lanyard cards. They posted redosing guidelines in the operating room and had updates to the hospital's antimicrobial manual. So in terms of results, they had a mean monthly compliance with redosing increase from 4.3 to 73% after the interventions. And they had an increase in compliance with the correct dose and timing, and improvement in timing. So they have kind of like a driver diagram with the key drivers that they were focusing on. So key one was being that EMR optimization, so looking at the anaesthetic medical record. They communicated the process changes. They had physical guidelines, and just there on the right is their key interventions. And I just wanted to show you the electronic countermeasures. So you've got the constant display of antibiotics that were given on the right side of the screen, and then it was displayed on the right side of the screen. It's on the left. It's figure A here, and it also has the medication administration window appearing, and at the bottom there, it's got the pop-up alert that they'll see 5 minutes prior to the redose. So this next article was published in March 2019. It's a study at Singapore General Hospital, and they introduced an antibiotic pop-up reminder to improve compliance in timing of antibiotic prophylaxis. So in terms of the method they used, they examined the workflow in the Anesthesia Information Management System, AIMS. So they too also had an electronic anesthesia record, and proposed interventions using cause and effect analysis of eligible surgical cases. So from that cause and effect analysis, it was identified that, lack of knowledge regarding timing of antibiotic prophylaxis, difficulty in obtaining certain antibiotics, difficulty in anticipating the incision time, and uncertainty regarding the choice of antibiotics, and lack of documentation when prophylaxis was not actually required. So the team determined then from that data that the largest contributors to the failure to document was a failure to document and lack of a time trigger. So it was for that very reasons that they modified their AIMS and introduced a pop-up reminder, which would be the intervention. So the reminder first pops up at the start when anesthesia is first documented in AIMS. The anaesthetist could then enter the timing and type of antibiotic administered. And if an antibiotic was not required, it was mandatory to actually specify a valid reason why not. And then again, the AIMS system would later have a prompt or a pop-up to prompt the anaesthetist when the antibiotic was due for redosing. So in terms of results, the median monthly compliance rate increased from 67% at baseline to 94.5%, and this improvement was sustained for over a year despite having frequent staff turnover. And documentation of antibiotic administration also improved from 81.7% to 99.3%. So it really demonstrates that application of IT can actually facilitate work processes and create really conducive platforms for change. So the last paper is a study in Dublin in a publicly funded university teaching hospital, and they were looking to improve SAP for orthopedic patients receiving joint replacements, hip fracture repairs or open reduction, internal fixation procedures. And we're really looking at the 4 elements of correct dose, correct drug at the correct time for the correct duration in accordance with their local guidelines. So they wanted to apply the model for improvement. So it's actually quite similar to the approach that we took here at the CEC. So the method was a prospective continuous interventional quality improvement project. So they created a Java diagram with interventions devised for their PDSA cycles, and then they had data fed back weekly using a point prevalence design. So the interventions included changes to their SAP guidelines. So they identified that there was a key issue with MRSA screening not occurring systematically preoperatively. And so what they did is change the default recommendation to using ticaplanin as choice of agent unless the patient had a recent negative MRSA screen, in which case they received cefuroxime. So this was part of this project, but now they're actually looking at improving the process for MRSA screening in these patients. Other interventions as part of this study was reminders and tools to support key messages. So this was in the form of posters which they put on a nursing medication trolley. So, empowering nurses to review antibiotic durations on the wards, and they included a hard copy of the updated guidelines in induction rooms for anaesthetists to follow by. And so results were positive in terms that prescribing appropriateness, which required them to meet all four elements. So correct dose, drug, time, duration, improved from 20% to 78%. So this is the diver diagram that they used. So you can see that their aim statement there is on the left. They've got their primary drivers, so they were focusing on education, developing reminders and tools, and streamlining the process of preoperative MRSA screening to inform antibiotic prophylaxis, which is kind of the next part of their work. And on the right there, you've got their key change ideas or interventions. Just wanted to share with you their driver diagram, their run chart, with which they've annotated with the interventions of PDSA cycles. So you can see that there's a trend going kind of upwards on the right-hand side, which is fantastic, and you can see all the PDSA cycles that they introduced or they did throughout the study. So the Institute for Healthcare Improvement, also known as IHI, was a partner in the American National Surgical Care Improvement Project, and they really identified that in order to improve or effective surgical infection prevention requires redesigning systems to reduce risk factors and to optimize evidence-based processes of care. And they've put together some strategies to improve surgical antibiotic prophylaxis prescribing. So there are 16 in total, just to highlight a couple. So designating responsibility and accountability for pre-op prophylactic antibiotic administration, the use of antibiotic standing orders specific to surgical sites, and providing a visible reminder or checklist to give antibiotics on each case. So there's utilising the electronic systems for those two studies that I shared. So other ideas was involving pharmacy staff to ensure timing, selection and duration are maintained. So in that US study that was looking at improving redosing in paediatric patients, they actually had a high compliance of initial perioperative antibiotic dosing due to them utilising the electronic record, but also that they had pharmacists involved. So pharmacists actually prepared the antibiotic for them. But I guess me sharing you all these strategies is to demonstrate that there are many different ways to improve surgical prophylaxis described in the literature. And really what's necessary is careful consideration of your context, your resources such as your human resources, but your IT systems as well, is really imperative and vital to helping you to choose the most appropriate interventions for your facility. So next I'd like to give kind of an introduction to improvement science. So improvement science is an applied science, and it emphasizes innovation, rapid cycle testing, and spread in order to generate learning about what changes in which context will actually produce improvements. So it's work occurring at the system level to improve the quality, safety, and value of healthcare. Improvement science is derived mostly from the automotive industry, so it takes a pragmatic approach to the reduction of poor performance in health. Improvement science differs from implementation science. So implementation is aimed at studying how to take proven evidence-based interventions and implement them into policy and practice with an intent to actually improve quality. So it begins with having an intervention that one actually believes will work, and then studying the approach to how they're going to approach it or to hardwire that. So the reason why implementation science is so important is just because an intervention has been shown to work in good scientific trials, it does not necessarily mean that reaping its benefits in the real world scenario is going to be particularly easy. So we know that in healthcare, it takes 17 years to spread a proven intervention. That's actually 16 and a half years longer than what it takes to spread innovations in the technological world. So implementation science is derived from behavioral science and focuses on a need to adopt new evidence into practice. I view implementation and improvement science as quite complementary. So implementation science focuses on timely and appropriate uptake of evidence, whereas improvement science focuses on measuring performance to achieve improvement. So in order to improve, there is a science behind it, and we need to have, firstly, an appreciation of the system. Secondly, an ability to understand variation. Third, a knowledge of psychology. And fourth, a theory of knowledge. So this is called the system of profound knowledge. And it was created by William Edwards Deming. He was an American statistician, professor, author, lecturer, and consultant. And what the system of profound knowledge is, it actually just provides a framework of thought and action for any leader who wishes to transform or improve their team or organization. So improving systems is really about appropriately applying the four components, or these four lenses, and practices so that the organization can simultaneously reduce costs through reducing waste and variation while increasing quality of healthcare. A little bit about the four lenses. So the first, appreciation of a system. So a system is defined as a network of independent components that work together to try to accomplish the aim of the system. And we know that sometimes making a change in one part of the system will actually have effects in other parts of the system. But an appreciation of a system requires that we avoid unintended consequences by optimizing the whole system as opposed to just changing one part. So understanding variation. So Deming's identified that there are two key types of variation within a system, and understanding variation is really critical to managing a system. So the first is common cause variation, which is also known as random variation, and these are problems which are inherently built into the system. And the second is special cause variation, so that's your non-random variation, and this represents unique events. So if you were to introduce changes, that would hopefully reflect as a special cause variation. And so what we aim to do is reduce common cause variation and build stable systems. And that's actually a key goal of effective system management. Knowledge of psychology. So Deming understood the importance of effective people management and accepted that people can't be managed in all the same way. So it's really understanding of how do people learn, how do people relate to change, and what motivates people. And the last is theory of knowledge. So this is based on the premise that management is about prediction and knowledge acquired as a rational prediction based on a theory of what may happen. This is then reviewed based on your comparison of prediction with your actual observations. And so this whole process is actually embodied in what we call the plan, do, study, act cycle. So we learn from something that we plan to do, we take in observations, and then we modify it to affect change. So now that we've spoken about improvement science, I'll talk to you about how we use that to improve surgical prophylaxis. So our objective here at the CC was to support and facilitate improvements in SAP use in New South Wales public hospitals, and we wanted to use a QI methodology to guide improvement and to drive better outcomes for patients and a more positive work experience for staff. So firstly, we gathered a multidisciplinary team. So we had surgeons, anaesthetists, surgical ward nurses, OT nurses, ID physicians, clinical microbiologists, and AMS pharmacists from different hospitals in different, metropolitan, regional, and rural in New South Wales. And we leveraged off their successes. So we learnt from what they had done in the past and identified what the critical success factors were. We then developed a suite of resources which were intended to be customised at the local level after an appreciation of the local context or environment where variation occurs in the process. And then we partnered with sites, so 4 hospitals, 2 regional, rural, and 2 metropolitan, to actually test these resources as well as use the QI methodology. So 2 of them actually have completed their projects, and I'll share that data with you in a bit. So like the Singaporean study that did a cause and effect analysis of the anesthesia information management system, we also did a cause and effect diagram of what contributes to inappropriate prescribing of antibiotics for surgery. And so this cause and effect diagram is also known as an Ishikawa or fishbone diagram. And it's an organisational tool that displays the many causes that contribute to a certain effect or outcome, and displays the relationships of the causes to the effect and then to each other. So it really helps teams identify areas for improvement.
Lolita,
So just to go over a couple.
Interrupt you. We have reached the end of our booking for the room. So I might leave the room, but I'd like you to finish your presentation. So I will make you the host and you can continue your presentation in the meantime, but we might have to leave the room in about a minute. But please feel free to continue presenting because we have online attendees. 1 second.
Okay, I'm sorry, running over time.
No worries.
Okay, I'll keep going then. Thank you, Arjun.
Okay, perfect. I've made you the host and I think it should be okay.
Thank you. Sorry about that. Okay. So just going over some of the key themes. So the first one is about people. So some causes to that problem would be a lack of awareness and knowledge of guidelines. If you look at communication, so what was identified in some of those studies I spoke to, the papers I spoke about was poor documentation of antibiotic choice, a dose. So having kind of that IT system that allows an electronic system to support that documentation is a fantastic change. There's processes and procedures being an issue. So, in that timeout phase, antibiotics are not a checkpoint. Environment, so we know that surgery operating theatre is a high pressure environment. There are time constraints. In terms of culture, there's habits of previous suboptimal practice, fear of failure, equipment. There are barriers to accessing appropriate antibiotics in dose, but there are many other causes to why antibiotics are used inappropriately in surgical prophylaxis. So we developed a suite of resources. The first one here is how to develop a local surgical prophylaxis guideline. So although we have the therapeutic guidelines as a national antimicrobial prescribing guidelines here in Australia, these guidelines can be amended at the local level, which could help to create a sense of ownership over the guideline and promote uptake and compliance. And then we also had a fact sheet on how to monitor surgical prophylaxis. So because it's now a requirement for accreditation, we included advice on how, when, and who should audit surgical prophylaxis, as well as suggest available tools such as the SNAPS tool or the New South Wales tags, quality use of medicines indicators, to collect this information and provide feedback to prescribers. We also developed template correspondences. So we've got a memo as a way to introduce regular SAP auditing in your facility. We've got a position statement of topical about the use of topical antimicrobials, as well as a memo to communicate these broad infection prevention strategies for surgical site infections. So these are all intended to be adapted and customized to the local level. We developed a driver diagram. So a driver diagram is a really powerful tool that helps you translate a problem in an improvement project into a single diagram, and can be used to scope a project and clarify the plan for reaching the desired aim. So you've got your aim statement there, which is a SMART aim statement, your primary drivers, which are the key areas that we need to address in order to reach our goal, and our secondary drivers, which are the actions we take to successfully implement those primary drivers, and then the change ideas, which are the specific changes that can help us implement secondary drivers. So the model for improvement is the framework that we used for this project, and it really relies around these three questions. The first of which is, what are we trying to accomplish, or what is it that we're trying to fix? The second is, how will we know that a change is improvement? So what can we measure to demonstrate that we have improved? And the last question is, what changes can we make that result in improvement? So what are some of the solutions or ideas that we're going to test? And which we'll test these via rapid plan, do, study, act cycles. So our approach was to teach improvement science to our teams. So we give teams the skills and knowledge. They created their own driver diagrams and cause and effect diagrams and use that to target their interventions. They analyze the local baseline data and allowed the data to show them what their target should be. So we standardized the approach there and not the focus. They devised their own measurement strategy. They collected small samples of data frequently. So that's 5 to 10 patient records weekly, collected on an ongoing basis, which is a really effective component of QI methodology. It can show whether changes being tested are leading to improvement, while also providing a sustainable audit method. We used run charts, a lot of them, and had regular meetings to discuss progress and plan PDSAs. So our two hospitals, so Hospital A was a regional-based hospital. They were looking at general surgery. They performed general surgery, ophthalmology, obstetrics and gynecology and urology. And for them, they wanted to focus on cesarean sections and cholecystectomies, in particular the correct dose and timing of administration of perioperative antibiotic. And Hospital B was a rural referral hospital of 280 beds. They wanted to focus on cesarean sections, in particular the documenting antibiotic administration time and the correct timing of perioperative dose. So it was quite interesting to note that the duration of post-procedural antibiotic prophylaxis, which was identified to be an issue in NAPS, wasn't really the case for Hospital A and B, whose baseline data showed that duration was not actually a problem in these procedures. So I'm just mindful of time, so I'm going to race through these. So these are the results. So for Hospital A, when we're looking at the percentage of patients who received the timely periodic antibiotics, you can see at baseline it was 25% and it improved to 70%. Patients receiving the correct dose, so baseline that was 60% to 90% after PDSAs. So I guess the key change idea was switching the vials of capsaicin that was stocked in operating theatres. Hospital B had a significant number of patients always missing the antibiotic administration time documented. So the direction we want here is for it to go down. So we want patients to actually have that documented. And so you can see that there's an improvement and a shift in the data on the right-hand side. And so the PDSA that was responsible for this is that they changed their process in which documentation of knife to skin and antibiotic administration time was written on a whiteboard and then transferred into IPM, so like an electronic record. And in terms of Hospital B improving patients receiving timely antibiotics, so there were multiple PDSAs which are annotated below, and you can see that there's gradual improvement over the time with a shift on the right-hand side. So to wrap up, why use improvement science? So QI approach is recommended when you're aiming to improve processes, outcomes, and reduce variability. We know that healthcare is dynamic and constantly changing, and that no two systems are the same. So QI really involves considering the context of the changes required, identifying any inefficiencies, variation, and preventable errors. Really useful to helping develop change strategies, and rapid PDSAs allow you to learn and refine your changes as you progress. So this is a diagrammatic representation of what QI is and some tips for using this specific approach. And I'd like to thank my colleagues, so some acknowledgements here. So Yvette Bueno, who some of this work might have been familiar because she presented this in May, so she helped with this project. My colleagues at the CEC, as well as my colleagues who helped in the surgical antibiotic prophylaxis working party. So I apologise for the time, and I'd like to thank you all for your attention.